All right, welcome back. Did you all do what I asked you to do? Did you all hear me ask you to do anything, or you were all just focused on, it's a break, go on? Who met somebody new on the break, on the little break? Only one person? 2 people, 3 people. Okay, great. Well, thank you very much for that, everybody. Welcome back. We're going to move on now to Your Heart Health is in Jeopardy. What is your wager? So we're joined this afternoon. You'll see we've got some Jeopardy names already up, so I'm not sure I need to tell you their names because they're up there, but let's go ahead. We've got Dr. Robert Piotrowski, who's the Heart Health Center's first U.S.-trained full-time cardiologist. He received his medical degree from the State University of New York, Downstate Medical Center in Brooklyn, New York. Dr. Piotrowski completed residency in internal medicine at Tufts Medical Center in Boston. He completed his general cardiology fellowship at Barnes Jewish Hospital, Washington University in St. Louis, Missouri in June 2015. And during his cardiology fellowship, he developed an interest in non-invasive cardiology and heart failure. He completed his cardiology fellowship and was hired by St. Luke's Mid-America Hospital to provide cardiology services to the people of the Cayman Islands. He's currently board certified in internal medicine, echocardiography, and vascular ultrasound, and will be taking his cardiovascular disease and nuclear cardiology board examinations this fall. He's also joined by Marcia McCoy, International Heart Care Director for the Heart Health Center, and Brian Ramza, who MD, electrophysiology cardiologist from the Heart Health Center. Marcia is the director of St. Luke's International Heart Care and coordinates the overseas advanced cardiovascular care for patients from the Cayman Islands at St. Luke's Mid-America Heart Institute in Kansas City, Missouri. She received her Master of Science in Nursing from the University of Missouri, Kansas City, and she proudly acknowledges that her 21 years of cardiovascular critical care nursing was instrumental in her passionate interest in women's cardiovascular health, entrepreneurial public health focus, and international health care. During her career, Marcia has received the University of Missouri Kansas City Alumni Service Award for outstanding service to the community and is a graduate of the American Hospital Association's Healthcare Forum Cardiovascular Health Fellowship Program. In 2003, she facilitated the visit of former First Lady, Mrs. Laura Bush, to Kansas City to promote the inaugural efforts of the Heart Truth campaign. She has been recognized as a pioneer in promoting women's cardiovascular health at 2 White House events, and most recently, she was named one of the most influential women of Kansas City. Congratulations. Yes, that's a clap. Dr. Brian Ramza, MD, PhD, is a board-certified cardiologist with St. Luke's Cardiovascular Consultants and is on staff at St. Luke's Mid-America Heart Institute in Kansas City, Missouri. He serves as the program director for the Clinical Cardiac Electrophysiology Fellowship at the University of Missouri Kansas City School of Medicine and is currently the principal or sub-investigator for over 15 research protocols at the Heart Institute. His expertise in cardiac electrophysiology covers a broad range of services, including extensive experience in the diagnosis of arrhythmias, pacemaker and ICD implantation, and catheter ablation for all types of cardiac arrhythmias. In addition, he has over 17 years of experience in the use of laser sheaths for extracting pacemaker and ICD leads. He received his medical degree and PhD at the University of Iowa College of Medicine, Iowa City, Iowa, and completed his internal medicine and fellowships in cardiology and electrophysiology at Johns Hopkins Hospital in Baltimore, Maryland. They're joined by Alex Trebek, I believe. Treblack. Alex Treblack, apparently. Who in his day job is known as Philip B. Banks. One of the owners and directors of the Heart Health Center. Ladies and gentlemen, please join me in welcoming all of our panelists for Your Heart Health is in Jeopardy. What is your wager?
This is Jeopardy! Thank you, ladies and gentlemen, and welcome to our show. I'm your host, Alex Treblack. Let's meet today's contestants. An electrophysiology cardiologist from St. Luke's Mid-America Heart Institute in Kansas City, Missouri, Dr. Brian Ramza. A cardiologist from the Heart Health Center here in the Cayman Islands, Dr. Robert Piotrowski. A registered nurse and international heart care director, also from St. Luke's, Marcia McCoy.
Excuse me, Alex?
Ladies first. Marcia, please start us off.
Oh, hello, Alex. Thank you so much for inviting us. I might say you look quite dapper.
Thank you.
Okay, thanks for inviting us today. Let's see. State of the heart for 100.
Your heart beats about 100,000 times a day and pumps blood through this many miles of blood vessels. Marcia!
What is 60,000 miles?
That's correct.
To put that in perspective, 60,000 miles of blood vessels is approximately the same distance from West Bay to East End 2,400 times, or traveling around the world 2.5 times each day. So let's take state of the heart for 200.
A condition in which the heart muscle has impaired ability to pump enough blood to the body's organs and tissues. Rob!
What is systolic heart failure?
Yes!
Oh,
I'll take state of the heart for 300.
Unusual fatigue, shortness of breath on exertion, persistent coughing or wheezing, swelling in lower extremities, increased heart rate. Brian!
What are signs and symptoms of heart failure?
That's it!
Okay, Alex, I'll take an apple a day for 300, please.
This percentage of premature deaths from cardiovascular disease and stroke could be avoided if the main risk factors are controlled. Rob!
What is approximately 80%, Alex?
Correct.
So this is really interesting. In the Nurses' Health Study, over 120,000 female nurses, we appreciate the nurses' help for that, were followed for over 20 years. These were women who maintained a desirable body weight, they ate a healthy diet, they exercised regularly,
yes.
and they did not smoke cigarettes. They experienced an 84% reduction in heart attacks and heart disease. A similar study in Sweden with men aged 45 to 79 showed exactly the same thing. So this is, I think, one of the most fascinating numbers that we're going to see today. 84% reduction in cardiac disease, in heart attack, through a healthy lifestyle. You can actually change your destiny. You know, many of us in this room, colonoscopies are very, very important to prevent colon cancer. And if anyone's ever had a colonoscopy, I would imagine that it's not a pleasant experience. And that prevents colon cancer. But imagine how much fun you can have walking on the beach to prevent heart disease. That's, Alex, I don't know about you. I think I'd rather walk on the beach.
I think so too.
All right. I'll take, how about an apple a day for 100, please?
This form of exercise is gentle, low impact, and suitable for people of most ages and abilities.
Got it.
Marcia!
What is walking?
Yes!
Well, walking has many health benefits. It lowers your HDL, the bad cholesterol, and at the same time, it raises your good cholesterol, the HDL, which truly is really hard to do without exercising. Walking also lowers your blood pressure. It really helps you maintain your weight. It also really overall is a good reduction, helps you reduce your risk for cardiovascular disease. And so aim to walk for exercise, at least 150 minutes per week or 10,000 steps a day. Why would you not want to walk on these beautiful beaches? So, Alex, I think there's an app for that for 100. That looks really interesting.
Map My Walk, Argus, and Nike Running are a few free options.
Oh.
Marcia!
What are easy apps for easy use for exercise apps?
Yes!
Oh, gosh. Oh, no.
Just got it.
I almost didn't get it. These are apps that are not just easy users for help people set goals or to track their distance or monitor their progress, but they also have data. You know, we all use our phones for so many things. You can actually load those things on your phone, and you can take the data and use it and take it and show your healthcare providers, because it's really important to actually use this information to help with your risk factor modification. So these really are beneficial, and there's so many out there. Some of them are complicated, some of them are easy, but try it. They're really fun and easy to use and beneficial. So let me think. Alex, how about a hard pill to swallow for 300?
When combined with a statin, these novel drugs have shown marked LDL lowering ability. Rob,
What are PCSK9 inhibitors?
that's right.
So these are really exciting drugs. When they're combined with a statin, we've seen marked lowering of LDL cholesterol. And they're currently designed to treat familial hypercholesterolemia, which is a condition where you have a genetic defect in your body's ability to handle cholesterol. But coming soon, I think we're going to see outcome studies as of December of 2017, where not only are we lowering the LDL cholesterol, but the combination of these medications with a statin may actually change cardiovascular risk. So we're really excited to see those outcome studies. Alex, I'll try time to intervene for 100, please.
The most common life-threatening heart arrhythmias seen in heart failure patients. Brian,
What are ventricular tachycardia and ventricular
That's correct.
fibrillation? Thank you.
Whoa. Oh, wow. This looks scary.
Just a quick instruction on what are these life-threatening arrhythmias. As you can see in the panel, this is an example of arrhythmias that were actually taken or interrogated from a device that treated a patient with ventricular tachycardia and ventricular fibrillation. ICDs, or implantable cardiac defibrillators as we call them, have been proven to decrease mortality in patients with these types of arrhythmias who have heart failure and decreased ejection fraction. What's important about this is that these arrhythmias in these high-risk patients actually occur on a random basis and usually occur without warning to the patient. And so when they do occur, they can be very devastating. Within a minute to 2 minutes, they'll cause syncope or loss of consciousness, and really within 5 to 7 minutes, they cause significant brain damage, and within 9 to 10 minutes, if they're not treated in a timely manner, they can cause irreversible death. And so it's very important to identify these patients who are at high risk and proceed with or recommend ICD implantation at that time. If you look at these two panels, you'll see this was the information that was taken from the device, and it was recorded through the leads that are actually implanted in the heart. This patient actually starts out with a very regular and rapid rhythm on the left at the top. And what the device sometimes can be programmed to do is try to pace the patient. We call anti-tachycardic pacing, that actually paces the heart just a little bit faster to try to throw it off its rhythm, and actually sometimes can terminate without having to shock the patient. In this particular instance, it goes through several rounds of what we call ATP, or anti-tachycardic pacing. And then in the panel on the right, you see that what happens is that this arrhythmia degenerates from a rapid, regular rhythm to a very chaotic, irregular ventricular fibrillation. And then the device has no alternative at this point but to actually shock the patient. And at the end, the tail end on the bottom right, you'll see that the patient gets shocked and goes back into sinus rhythm. And so what's important about this is this took this device all less than 30 seconds to interpret this rhythm and treat it effectively, thus saving the patient. Alex, I'll take time to intervene for 200.
A procedure that scars the cardiac tissue by freezing or burning small areas of the heart muscle to treat arrhythmias.
What is cardiac ablation or catheter ablation?
Yes.
Oh, darn.
You didn't even call on him.
Yeah, we hit our
What-
buttons.
what
We hit
is
our buttons
cardiac
first.
ablation?
Come on, don't cheat. No cheating.
I think this game is rigged.
I think so. Brian, want to take that one?
Thank you. Just a brief description of what is cardiac ablation. For patients with cardiac arrhythmias, there are a few selected medications out there that are actually used. We call antiarrhythmic medications. They're used to treat or suppress all types of cardiac arrhythmias, whether they're the more benign, such as atrial fibrillation or atrial flutter, or the more life-threatening, such as ventricular tachycardia and ventricular fibrillation, like you just saw. Sometimes the patient develops side effects, serious side effects from the medication, and sometimes the arrhythmia or the patient develops a tolerance to the medication where it no longer works. For example, in atrial fibrillation, the track record for antiarrhythmic medications is about 30% at 1 year for still being effective. So when this happens, there are procedures like this called cardiac or catheter ablations in which plastic-coated wires are inserted through the femoral veins in the leg and directed or parked in different areas of the heart. And from there we can figure out where the aberrant or the wrong circuit is and actually deliver or insert another type of catheter where it can deliver radiofrequency energy which actually cauterizes the tissue, or cryoablation where we actually freeze the tissue and can render that aberrant circuit inoperable. And many times, on the average about 90% of the time, it's a very effective type of procedure. It's also, despite being more invasive and second line of therapy, it's really usually associated with very low risk profile. And the patient really is comfortable during the procedure with mild sedation. A lot of times the patient goes home the next day. So now it's becoming more of a first-line therapy over antiarrhythmic drugs in some circumstances. I'll take state of the heart for 400, please.
This novel agent has decreased the risk of cardiovascular death and heart failure hospitalization in New York Heart Association Class 2 through 4 patients. Rob.
What is Entresto, or also known as valsartan sacubitril?
That's right.
So this is a really exciting time for heart failure. This is the first new drug, okay? Yeah. Not if you have heart failure, but as a physician who treats heart failure. Yeah. Really, really tremendously exciting. This is the first breakthrough drug that we've had in about 30 years. In a randomized controlled trial, it went up head-to-head versus standard of care therapy, ACE inhibitors, and it decreased mortality by about 30%. We haven't seen a drug that does something like this for systolic heart failure in the last 30 years. This is going to revolutionize systolic heart failure. It's a combination medicine of one heart failure medication, an ARB that we use all the time, and a new pathway, a very exciting new pathway called a neprilepsin inhibitor, and that's the sacubitril component. But we're trying to get it here to the Cayman Islands, and I think it's really going to change the way we treat systolic heart failure and heart failure in general. Alex, I will take, there's an app for that, for 400, please.
Information from implanted pacemakers or implantable cardioverted defibrillators is transmitted from patients in Cayman and interpreted hundreds of miles away. Brian.
What is remote monitoring?
Correct.
Thanks. Just a brief note on remote monitoring. As we know, both pacemakers and defibrillators can restore massive amounts of information, and a lot of this information pertains to either arrhythmias which the device isn't programmed to treat, it doesn't know how to treat it, doesn't know what to do with it, so actually it stores it, it records it and stores it. In addition, these devices actually perform daily checks to look at the integrity of the system. So it makes sure that the leads are working fine, that the circuitry is working fine, and it stores that as well. Traditionally, patients used to have to come into the office to download this information and look at it to get a check to make sure everything was working fine and there were no other serious arrhythmias. Now with remote monitoring, the patient actually goes home with a box that sits at home. The box communicates with the device through radio frequency, talks back and forth, and actually collects the information, sends it using wireless technology over satellite, and actually we can retrieve that information in Kansas City. I can look at it, and then I can talk to or share this information with Dr. Piotrowski, who is a very dear friend and colleague, until 6:30 tonight when the game starts, who's a true Mets fan, and I'm a Royals fan. In any event, he's okay. So we share that with him, and then he can actually treat the patient on the island without the patient ever having to leave the Cayman Islands. Let's do, there's an app for that for 500, please.
This is the first FDA-approved MRI-compatible pacemaker. Brian again.
What is the Medtronic Revo
It's
MRI
cheating.
SureScan
Right
pacemaker?
again.
So,
Is he going to let us play?
My buzzer's not even connected here.
What's happening? I don't think the electricity's on.
So until 2000, this was this has a big impact on many patients. Until 2011, patients who were implanted with a pacemaker defibrillator really could not undergo MRI scans or MR scans. And this is important for diagnosing very critical diseases such as cancer, strokes, and orthopedic issues. And in 2000, and the reason for this is that the MR scanner, with its large magnet and the large amounts of energy that it generates, really creates a hostile environment or hurricane-like environment for the delicate circuitry of these devices. So many times it has the potential either to destroy or harm the device, or in some circumstances harm the patient. And so as a result, patients really couldn't have an MR scanner until this was developed. The design was actually built so that it could withstand this type of environment. So what's important, though, is that up until 2011, those patients who have been implanted still can't have MR scans because either their leads or the device is still not MR compatible. So we have one of our colleagues who is a visiting cardiologist to the Cayman Islands, Dr. Abraham Said, and is also a colleague of mine in Kansas City, who is an expert in MR technology, has actually been able to develop protocols. There's only a few select institutions in the United States that have developed protocols that can have patients who don't have MR-compatible pacemakers or defibrillators scanned in a more safe way to minimize complications as a result of that. So that's become very important for anybody that was implanted before 2011. There's an app for that for 200, please.
Weighing just 1 ounce, this small lightweight device is used for monitoring arrhythmias. Rob!
What is the Mortara H3 Plus Halter monitoring system?
You got it.
Yeah, you know, we're at the Heart Health Center, we were very excited to have our first Halter monitor that came in last week, and Halter monitoring has changed just completely. It's used for picking up palpitations, diagnosing arrhythmias, diagnosing pacemaker complications. But when I first started training, they were big, bulky devices. Patients really hated to wear them. You have to wear them for 24 or 48 hours. And you can see in the picture, it's just such a small, lightweight device. It runs just on a battery. So really improving technology and making the patient experience a little bit more comfortable. Alex, I'll try. How about there's an app for that for 300.
Rob, you only have to hit your button once.
I want to win, though. That's
This device, base therapy, is used in heart failure to improve how the heart functions. Brian.
What is CRT, or cardiac resynchronization therapy?
Correct.
The damn button.
Thank you, Alex. Just a short no. What is CRT? As you can see from these photos, these are actually echocardiograms or videos. And on the left, you can see the echocardiogram of really a normal heart. The left ventricle, as you see it, is actually the top right-hand corner of that of the four-chamber view. And you can see that when the heart beats in normally, there's essentially synchronized normal contractility within the heart. In some patients on the right is a echocardiogram of a patient who is much sicker with cardiomyopathy and ejection fraction probably that we would label in the 10 to 15% range. And as you can see, there are actually two videos there. One is what we call off, which is cardiac resynchronization therapy off, and one is on. What happens with CRT, or what happens with some of cardiomyopathies, is that patients develop what we call dyssynchrony. And as you look closely, you see that not only is the heart not beating vigorously, but that the walls of the left ventricle, which is the largest chamber there, are beating asynchronously. And so what happens with cardiac resynchronization therapy, we strategically target or put in pacemaker leads to each of those walls so that we can coordinate the contraction of the heart. And so when I explain this to patients, I first tell them that it's like having an eight-cylinder automobile and only 4 cylinders are working. And when they have dyssynchrony, those 4 cylinders are out of timing. With CRT, it coordinates or applies proper timing to the heart so that it can help in some ways. As you can see, it really doesn't improve how well the heart contracts. They still end up with 4 cylinders, but what happens is that it optimizes the timing. And in some patients, up to 70%, this has some effects clinically in how they feel. And many times they can help improve their New York Heart Association functional class by an entire class, from 3 to 2 or from 4 to 3.
Wait. Am I ever going to get to play? I only have 300.
It's time for the Daily Double. Maybe you'll get a chance now. Contestants, buzz in.
Oh,
Rob.
Yes.
Rob, with 1,400, you're in second place.
of course.
Brian is 400 ahead of you with 1,800.
course.
How much would you like to wager?
We're not playing poker.
All right. I won't go all in.
No?
No.
How about 500?
500. While Shakespeare, King Lear died of a broken heart, this cardiomyopathy is frequently reversible.
What is Takotsubo cardiomyopathy?
You got it. That brings you to 1,900, and you're now in first place.
So thank you, Alex. So Takotsubo cardiomyopathy is really a fascinating disease. We see it as cardiologists kind of about once a year or so. Usually it's in a middle-aged or elderly woman who experiences severe emotional distress, the death of a loved one, and it truly is called the broken heart syndrome. And what can happen is you get such a release of adrenaline from the body that it affects the heart. And the bottom part of the heart, the apex, actually balloons. And it resembles, it was first described in Japan, and it resembles a Japanese octopus pot, which they call a takotsubo, where the bottom flares out and the top part of the heart really starts contracting more than it did before. So fascinating disease, and as far as a cardiomyopathy, these patients are really sick. They're complaining of chest pain, they're in heart failure, but with standard heart failure therapy, within a couple of days, everything is completely reversible. So one of the few reversible cardiomyopathies that we have, we love it when we see it as a cardiologist, and it's great for the patient because they're better within days or weeks. So, Alex, I'll take an apple a day for 200, please.
This celebrity paired up with the American Heart Association to help raise awareness about heart failure. Marcia!
Yes.
Finally.
Who is Queen Latifah?
Correct.
Oh, gosh. In 2013, the American Heart Association stated that heart failure had become a major public health problem, and with the prevalence was more than 23 million people worldwide. So Queen Latifah's mother, Rita Owens, was diagnosed with heart failure about 11 years ago after passing out of school while teaching art at a New Jersey high school. Queen Latifah's mother has always been very supportive of her personal life and career, and now it was her turn to support her mother. And this past World Heart Day on September 29th, Queen Latifah and her mother, in conjunction with the American Heart Association, launched a wonderful program called Rise Above Heart Failure. So I'd like for you, when possible, go to riseabovehf.org and assess the online tools that are aimed to changing the course for heart failure for those people that do have heart failure, or for yourself in your offices, that promote awareness, education, and support. So there are some wonderful, wonderful tools. One's called green light, yellow light, red zone, red light, whatever. And they're wonderful tools for you to give to your patients that let them know when they're doing well, when they're in trouble, when it's an emergency, that can help them from preventing them from emergent hospitalizations. It's really, really a great website. So let's see, Alex, I think I might like a hard pill to swallow for 100, please.
3.8 billion prescriptions are written in the U.S. each year.
Oh.
Wait for it. Yet this percentage of medication is taken incorrectly or not at all.
Oh.
Got it.
Good. What is 50%?
You're right again.
Shocked? Don't be. A study of over 75,000 commercially insured patients found that 30% failed to fill new prescriptions. And new prescriptions for chronic conditions such as high blood pressure, diabetes, high cholesterol were not filled about 22% of the time. These percentages are probably very similar to here in Cayman. So let's look. These are probably really very emerging trends here, because the World Health Organization estimates that by the year 2020, 49% of Americans will be affected by at least one chronic condition requiring medication therapy. This is only going to compound the current public health crisis that we're facing related to heart failure. So why aren't our patients compliant with their medications? Understanding possible barriers that allows healthcare providers to help their patients improve compliance is really important. So let's consider some of the possible barriers that exist. So what about health literacy? I'm going to give you a couple of examples that I've experienced myself. Oftentimes we write prescriptions for 30 days. And if you don't explain to your patient what that really means, what happens? They stop taking the prescription after 30 days. They take the pills until they're gone. And so they stop. So what if that's something that you're giving them for high blood pressure or for an arrhythmia? That really causes a problem. What about medication shortages? Frequently when I'm transferring a patient back to Cayman after they've been at the Mid-America Heart Institute, and the patient really isn't really quite stable from a labile perspective after their procedure, or they're on a special medication, I'm calling my friend Angelina Schillingford at the Georgetown Pharmacy to make sure they have this medication. And on occasion, they've not. And so we've had to be really creative in either changing the medication or maybe them bringing something with them to make sure that they can continue the medication and be compliant. What about their fear of side effects? You know, we frequently are constantly talking about the side effects. Why do we do that? Why instead aren't we talking about the effect of the medication and the value that the medication has? Our patients are, you know, Google, the internet, they've kind of become, have become our worst enemies. They're always watching TV or looking up something and bringing in their lists of, this says that this is a side effect or this is bad for us. So instead, maybe focusing more on what the effect is and the benefit of the medication, and then certainly the cost implications. So a few steps to help our patients be successful: provide written instructions and really explain in detail why it's important. Hopefully the patient brings a family member or their caregiver with them and make sure that they are there and helping understand why it's important for them to take these specific medications. So the reason for the medication, the purpose of the medication, and the directions in taking the medication. Those are so complex because, especially with patients with heart failure, how many medications are they taking? Encourage the use of a pill box. I can't tell you, I don't understand how people take medicines out of a bag. I don't get it. I'd be lost. I'd totally be lost. It's not uncommon for a patient to come in and say, I'm taking 11 medications, but I think I just took 9 this morning and I'm not sure which ones I'm missing. What? What does that mean? But they don't know what they've taken and what they've not. So it's important for them to lay their pills out for the week. It's important for them to be laid out in morning, afternoon, and evening. Encourage that kind of organization. I'm sure that's not how they do their banking. Maybe it is, I don't know. But they need to take their medications that way as well, so that they have well-controlled and managed heart failure. Ensure that the patients understand their risks for not taking the medications. That's so important. Again, how can we help them manage their disease process if they don't understand that? And then encourage the patients to understand the benefits of taking the medicine. It will slow down their disease process. We're looking to help them improve their quality of life. They want to do things with their children, their grandchildren, especially if they have progressive or end-stage heart failure. These are very important. Encourage the patients to call you if they feel like the medication, if they don't like the way they feel, instead of stopping the medication. Again, these little tidbits, especially if the caregivers with them. Review the medications for compliance at each visit. Have them bring the medications with them so that you can review it with them so you can see what they're taking. And ask the patient to call you if the medications that they're getting are not available at the pharmacy. So important that we can continue to help them with their compliance and with the management of their heart failure. Alex, I think I would like a hard pill to swallow for 200, please.
The ejection fraction is 70%.
Oh!
Marcia!
Oh, sorry. What is diastolic dysfunction?
Correct, she's on a roll.
Wow. There are two types of left-sided heart failure, systolic and diastolic heart failure. Actually, the heart is really an amazing pump. Every single heartbeat reflects the cycle of the heart contracting and relaxing. So systole is when the heart pumps the blood out and it goes out to the body. And diastole is when the heart's relaxing and it's filling. It's supposed to be that relaxing, wonderful feeling and sensation. Well, in diastolic heart failure, the left ventricle or the lower chamber of the heart, it loses its ability to relax. It doesn't enjoy that wonderful feeling. It's tight all the time. Like when you're lifting weights and you're building muscle, that's what's happened with your heart. It doesn't have the ability to fill completely. So the amount of blood that it's able to eject isn't adequate. So patients with diastolic dysfunction or diastolic heart failure typically have an ejection fraction of greater than 50%. And it's not uncommon to see an ejection fraction of 70% or more on an electrocardiogram report. So that sounds really good, doesn't it? But it's not. In systolic heart failure, the left ventricle or the lower chamber of the heart doesn't contract normally, so it's not ejecting all that blood out like it should. And that typically is due to an injury of some type. And so the heart muscle is floppy, it's thin, it's large, and the blood really can't pump out as much blood as it needs to get to all the major organs in the body. And so it tends to then cause swelling, edema, or congestion in the lungs or around the heart. So patients with systolic heart failure, you'll see an ejection fraction, or they will have an ejection fraction of less than 40. So I think, Alex, I'd like to take time to intervene for 300.
Every heart failure patient should have these two measurement tools in their home.
Oh,
Marcia.
oh gosh, I'm sorry. Oh, what is a blood pressure cuff and a bathroom scale?
Right again.
So keeping track of blood pressure and weight is crucial in managing heart failure. So it's normal for every patient. It's really important for every patient to know what their weight is, or their dry weight, because when you're at home, they really need to weigh themselves every day, because a weight gain of 2 pounds or more every day, or 5 pounds a week, is something they really need to call and talk to their healthcare provider about, because that could be the difference between being admitted to the hospital or not being admitted to the hospital. The same is true, or the opposite is true, for someone who's taking a diuretic or a water pill. If they were to lose 4 pounds or more per week, then that means that they're also, it could be we call it dry, and that could mean that every time they get up, they're really dizzy, or they are they're incoherent. And so we need to be able to monitor that as well. So it's so important to understand what your weight is every day. That's one of the very, very important things that you have to do. So some simple steps to remember is that weigh yourself, or ask your patients to weigh themselves every morning when they get up after they empty their bladder, after they go to the bathroom. Always use the same scale on a solid surface, no carpet. Actually, it's easier, especially for older people, to use a digital scale so they can see a number instead of trying to figure out where that little peg is. Have them check their blood pressure and their heart rate before they take their morning medications. Write all of these numbers down in a journal on a log. Every time they go to the doctor, I don't care if it's their primary care physician, their cardiologist, they must take this log with them. This is how we're going to help them manage their heart failure, titrate their medications, and keep them healthy and optimize their health. So I think I'm gonna take time to intervene for 400.
An alternative to a mitral valve replacement in high-risk surgical patients, this procedure treats severe forms of mitral regurgitation. Brian.
What is a mitral clip?
Yes.
What is a mitral clip? Well, traditionally, patients with symptomatic severe mitral regurgitation who develop recurrent heart failure, after medical management, the only thing to offer them is really open heart surgery to actually repair or replace the valve. This has become very difficult in high-risk patients who either are the frail elderly, patients with pulmonary disease, or end organ injury. And so there's now a minimally invasive technique called the mitral clip, in which no open heart surgery is required. There's a large catheter that's, as you can see in the figure, that is inserted through the femoral vein, and it enters the right side of the heart, and then through a transeptal technique, we puncture a hole, go into the left side of the, into the left atrium. From there, if you can imagine in traditional mitral regurgitation, the leaflets are going back and forth. In a normal heart, in a normal valve, when they close and oppose directly, and so the blood can't flow backwards. With severe mitral regurgitation, they're just flapping in the breeze, essentially. And so what the mitral clip does is it's actually a clip that connects at the center of the valve the two leaflets. And so blood can still flow through, as you can see on both sides of the clip. It allows blood to flow back and forth, but it decreases the amount of mitral regurgitation. And a lot of times, these patients feel much better the next day. Overall, there's been 20,000 of these procedures done globally. And in the United States, we've done approximately about 1,200. 900 of these have been followed for over a year. What it translates into is that this is a very minimally invasive technique. Patient feels better. Patients usually go home within, on the average, about 2.7 days. From our institution, the majority actually go home the next day, and these are very sick patients. And overall, it accounts for a reduction in heart failure hospitalizations by 73%. Okay, Alex. May I take time to intervene for 500, please?
This device was recently approved by the FDA to diagnose and treat NYHA Class 3 heart failure. It measures pulmonary artery pressures. Rob?
What is the CardioMIMS device?
Yes.
So this is a really fascinating device. It's the size of a dime over there. It's parked via a catheter into the pulmonary artery, and it actually gives us remote readings of the pulmonary pressures. It's the first of its kind. So just like when Dr. Ramsey places devices in the heart, and they have wires, and that can tell us what's going on with the heart. As a heart failure doctor, we can actually know real time when our patients are starting to gain weight, starting to have higher filling pressures in the lungs, and we can change their medication before they get to the hospital. So truly an amazing device. Alex, I'll take an apple a day for 400, please.
Your daily recommended intake of this was recently reduced from 2,500 milligrams to 1,500 milligrams. Marcia?
What is the daily recommended intake of sodium?
Correct.
The American Heart Association has recommended a daily sodium intake of 1,500 milligrams for everybody. I don't care if you have heart failure or not, so don't be mistaken. A teaspoon of salt right here is equal to 2,400 milligrams of sodium, a teaspoon. Because sodium attracts water and it absorbs it, so this is what the problem is when people eat sodium that have heart failure. The end result is it increases your blood pressure, increases fluid, and so the heart's having a hard time pumping that extra fluid around. So 77% of our sodium that we have isn't from the table, isn't from table salt. It is from the processed foods that we eat and eating out. So we have to be very careful about the foods that we're eating. Select foods that are 140 milligrams of sodium or less. So you need to learn to read the labels. Foods that are more than 300 milligrams of sodium per serving don't fit into that low sodium diet. Learn to read the labels. Guess what? These 5 crackers are a serving of crackers. This is equal to 135 milligrams of sodium. This is not a serving of crackers. All right, Alex, I'm going to take an apple a day for 500.
This condition affects 15% of all adults and 30 to 50% of all cardiovascular patients. Rob?
What is obstructive sleep apnea, Alex?
Yes, that's right.
Yeah, so obstructive sleep apnea is a really big problem in heart failure and just in general, okay? And traditionally it's thought that people who are overweight are going to have problems with sleep apnea. The trachea is going to obstruct the flow of air when they sleep. They're going to stop breathing. It's going to put them at risk for heart arrhythmias, sudden death, and hypertension. The treatment of sleep apnea is really important, especially from a heart failure standpoint, because when you're not breathing, the heart is straining to provide oxygen. So 50% of people have this condition, 30% of our heart failure patients have it, and it doesn't matter whether you're overweight or skinny, you're actually at risk for it. So I urge the primary care doctors to ask their heart failure patients about this very, very important condition to treat, and the CPAP, the machine that actually treats it, can wipe out the sleep apnea. So great treatment for it. How about case in point for 100?
This is a 68-year-old non-smoking female with a history of hypertension, type 2 diabetes, and obesity. Presents with complaints of shortness of breath with stares. EKG shows normal sinus rhythm, left ventricular hypertrophy, Myocardial perfusion imaging shows no ischemia and normal ejection fraction. This is her diagnosis. Brian.
What is diastolic heart failure or heart failure with preserved ejection fraction?
That's right.
So diastolic heart failure is actually a very difficult type of heart failure to treat. But if you look at it, the prevalence is quite high. If you look at it in many studies with heart failure, sometimes these patients account for more than 50% of the heart failure patients. And really what happens is what's different from systolic heart failure where there's poor pump. This actually has a normal pump, as Marcia was talking about, but the walls are much thicker. And so what this translates into is poor compliance. And so what happens is that the heart pumps fine, but it's hard to fill it because it's so stiff. It's like if you blow up two balloons, one's very easy to blow up, one's hard. You have to work harder at blowing up the much more difficult or stiffer balloon. And this translates into the left atrium having to work harder, and it's just not constructed or designed to do that. So what happens is that you end up with blood flow back into the lungs, pulmonary vascular congestion, and heart failure. It's very frustrating for both the patient and the heart failure doc because the only treatment is really diuretics. And it doesn't take much volume overload to really put these patients in heart failure. And then when you do treat them, it's very easy to aggressively over-diurese these patients. And what happens is they end up with acute kidney injury, and then they're in the hospital longer waiting for their kidneys to recover. So they walk a very fine line in what's too much volume or too much fluid and what is not enough in these patients. Alex, I'll take case in point for 200, please.
This patient undergoes an echocardiogram. Based on her Doppler data, her left atrial pressure is, Rob.
What is elevated?
Yes.
So if we look at the Doppler here, first image on the left is going to be the mitral inflow, and the first tall peak we see is what we call the E wave. That's the flow in early diastole. The second peak is what we call the A wave. That's the atrial contribution. Usually atrial contribution is only about 20% of all heart filling. We have tissue Doppler on the other side, which is now showing the movement of the mitral valve as it fills the heart. We look at the E over E prime ratio, and anything over 15 tells us that the filling pressure is elevated. This heart can't actually relax, and it needs high pressure to fill the heart. I'll take case in point for 300, please.
Control of blood pressure, weight loss, exercise, and this are examples of lifestyle modifications that will improve quality of life with heart failure. Marcia.
Oh, what is reduced salt and sodium intake?
Correct.
Well, we've already talked about the fact that dietary salts and sodium lead to increased water absorption in the kidneys. It increases overall circulation of blood volume, and so for an already weakened heart, that really exacerbates heart failure. So a simple snack of cheese and crackers or a patty really could exacerbate my patient's heart failure. So ready for some tips for success from Marcia? I hope you are. Anyway, so some of your favorite recipes don't have to be bland. Be creative. Try different kinds of seasonings, different kinds of salt-free spices. There are a lot out there in the grocery store. You just have to take time to shop. Salt-free canned and frozen vegetables are good alternatives. You can use canned vegetables. They just have to be rinsed. Avoid canned, cured, and smoked meats. Everybody thinks that deli turkey's healthy. You need to look at how much sodium's in there, and they're talking about a serving, which is slices. You have to look at a slice. Sometimes they're as high as 500. Did you know that the most convenient items are high in sodium, and some of your favorites are the worst ones? How many of you like these little things, right? Right? Okay. This is 1,500 milligrams of sodium right here. Actually, half of this is a serving. How many of you eat a whole one, right? Okay, and guess what? This and this don't go together. Just want to clue you in, they don't go together. Want to make sure you all realize that. And then some of the things that you like that are sweet, some of the sweet labels, like the sugar, the cereals. Read the cereal labels. How many of you eat like instant porridges, like the oatmeals? This happens to be what is this?
Cornmeal.
Oh yeah, cornmeal. Oh my gosh, you guys, just look at the instant, like the regular oatmeal. It has 0. This has 370 milligrams of sodium. Look at the simple things, learn to read the labels. And you all think that the little green hearts on the cans are supposed to make them healthy? Huh. Okay, so they may not have any fat, may not have any cholesterol, but guess what? This has 1,100 milligrams of sodium. How many of you eat the whole can? This has 2.5 servings in it. This is not just one serving. So you have to learn to read the labels. You have to think. So go on the preface that 360 milligrams of sodium per meal is all you can have. Consider referring to a dietitian if you need help, if your patients need help with sodium. But we've got to become smarter. Remember, 1,500 milligrams a day. Hard pill to swallow for 400.
Marcia out. I like that.
A subgroup analysis of the TopCat study indicated that this diuretic significantly decreased heart failure hospitalizations in the Americas. Brian.
What is spironolactone?
Yes.
So what is the TopCat study? TopCat study is actually a mouthful to hold. It stands for the treatment of preserved cardiac function heart failure with aldosterone antagonists. Essentially, it was testing spironolactone in a very large population of patients. It covered both North America, South America, as well as Russia and Georgia. And really what they tested for was, did it reduce, the primary endpoint was reducing cardiovascular mortality, the aborted life-threatening cardiac arrhythmias, and heart failure or hospitalizations. And initially it didn't show that, but when you separate it out in a post-hoc analysis and you just look at the Americas, it does show that it reduces heart failure hospitalizations. And like I said before, with diastolic dysfunction, diuretics are really the only primary treatment for diastolic heart failure. The only thing you have to be wary of is that, again, it's a diuretic. Watch your creatinine, watch your renal function when you treat these patients, and it does preserve potassium, and they do get hyperkalemia or high potassium levels, so they do have to be tested frequently with their labs. Heart pill to swallow for 500, please.
This class of medications has been shown to be of no benefit and may even cause harm in patients with diastolic heart failure. Rob.
What are pulmonary vasodilators?
Correct.
And so this is really interesting stuff from the RELAX trial. RELAX trial came out about a year ago. It was the talk of the town. They were using sildenafil, which is also known as Viagra, to treat diastolic heart failure. The surprising thing was there was no benefit whatsoever. Actually, when you dilate and use pulmonary vasodilators, you may actually cause more harm than good. You'll get increased flow through the pulmonary bed, and you can actually worsen the pressures that the patient sees and the congestion. So there's a slight benefit from pulmonary vasodilators for systolic heart failure that doesn't squeeze very well. But in the relaxation problem, do not use pulmonary vasodilators. I'll take case in point for 400, please.
Because of this, the patient was able to reduce her swelling, improve her breathing and quality of life, and stay out of the hospital. Rob.
What is a multidisciplinary approach to care?
Yes.
So multidisciplinary teams, we heard it from Dr. Windhaber, patient empowerment, lifestyle modifications, pharmacological therapies, device-based therapies, collaboration between the primary care doctors, the specialists, the ancillary personnel. It can really result in better quality of care, lowering of costs, and improved outcomes. I'll take case in point 500, please.
Helps our local medical and healthcare professionals keep abreast of changing trends in technology. Marcia.
Yes. What is Cayman Islands Healthcare Conference?
That's correct.
Woo! By uniting experts in our field, we have the opportunity to collaborate, share ideas, and as Honorable Eldon McLaughlin said, we can work towards achieving a better experience for our patients and a healthier country as a whole. Whether you're part of a medical community, a business owner, a human resource manager, an insurance company, a fitness wellness professional, or part of the general public, we all have the responsibility to work together, hopefully implement some of the key learnings from this year's conference, and not just talk the talk, but walk the walk.
That concludes this round of Jeopardy! Thank you, Brian, Rob, and Marcia.
Yes.
But we still have Final Jeopardy, and we're inviting the audience to participate. At each seat, you'll find a Jeopardy ballot. Please locate your Jeopardy ballots now and find a pen and get ready for Final Jeopardy. The winner of Final Jeopardy will be selected by a random draw, but you must have the correct answer to win. The Final Jeopardy prize is a gift basket filled with many great goodies, including a gift certificate for a Swedish massage here at the Ritz-Carlton. Total approximate retail value of the gift basket is $3.50. Here's your final Jeopardy question. We can all lead by example and walk the walk Cayman. To help reduce your risk of cardiovascular disease, aim to walk this many steps each day. 30 seconds, good luck.
I got my goods.
Thank you for participating in our final Jeopardy round. Please submit your ballots at the Heart Health Center in St. Luke's booth in the room next door for a chance to win the gift basket. Our panel leaves you with this quote by Zig Ziglar. Among the things you can give and still keep are your word, a smile, and a grateful heart. Thank you all.
Thank you very much, all of the contestants. Who won? I wasn't keeping track. Rob, big cheer for Rob. Rob won. All right, we do have a token of our appreciation for you. Did you guys enjoy that? Yeah, it was great. Something a little different. So just thank you very much. Oops, sorry.
Thank you so much.
Thank you very much. Alex Treblack.